Hi, everybody. This is Glenn Woodworth with the Society for Education in Anesthesia, and I'd like to welcome you to another one of our Innovations in Anesthesia webcasts. And today it's my great pleasure to have Shen, and he is an assistant professor at UC Irvine in the Department of Anesthesiology and Perioperative Care Medicine there. And he specializes in critical care medicine, and he's also the director of their point of care ultrasound in his department. So it's fantastic that we have him here today because he's got a great project to talk about on developing an OSCE for point of care or POCUS ultrasound skills. And so, Jay, thanks so much for joining us today.
Thank you, Glenn. Thank you so much for having me. It's a great pleasure and a great honor that you guys even basically allowed me to speak on here.
Oh, no, you've got a great project, and we're really, really excited to have you on today.
Absolutely.
So the first thing I'd like to ask you is, what was the driver behind your project? What was the problem that you were trying to solve that got you involved in this?
Yeah, absolutely. I think that there definitely were three parts to kind of this problem that we were kind of trying to solve. So the first part started, and it really was a problem with performance and knowledge. Point of care ultrasound is a super new and innovative tool in the up and coming years, and it's been increasingly growing in demand also. And the first problem I noticed during actually my residency was that we got all this point of care ultrasound training and different things like that, but when it came time to perform under pressure, when you actually needed to use those ultrasound skills on a critically ill patient or a fresh trauma patient that came into the operating room, oftentimes you weren't able to get the views that you needed to get, and simply because this is you're performing under pressure, very similar to as if you're playing basketball and you're shooting those free throws over and over and over again during practice, but then afterwards, when you get to the live game and the crowd is roaring and everything is happening, you miss the free throw, right? It's kind of the same thing with point of care ultrasound. So the very first problem that we noticed in our residents and in myself when we started doing this was a performance and knowledge issue. And how we addressed this first was to start a good curriculum to ensure that their training is complete and accessible to the residents in itself. Right? And then, so how we kind of approach this problem of performance was, well, how we're going to go about evaluating this performance. And this is how the point of care ultrasound OSCE solution was born. And we thought that, well, maybe if we actually tested our residents under pressure and asked them to perform live the things that they needed to perform under a time limit and in a very specific format, basically that we would be able to train them better for live situations.
When you brought up, I think, a couple of interesting points, because I would say, from my knowledge in the field, that UC Irvine actually was one of the leaders in point of care ultrasound teaching. And so you had developed a lot of educational materials. So I actually would have thought that your residents actually had a higher knowledge and skill level, perhaps, than maybe other programs that didn't have a sophisticated faculty and training resources. But it sounds like what you're saying is that despite that, the education didn't have enough practical application in real world scenarios that led to a performance deficit. I don't know if you wanted to comment on that.
I think you hit kind of the nail right on the head there, Glenn. I think that I underwent the thing that you're kind of referring to was the study that was published back in 2012 called the Focus Perioperative Risk Evaluation, basically the Foresight curriculum. It was published on the front page of anesthesiology back in 2012, and I actually went through this curriculum that UC Irvine developed, and it was a great curriculum, and I think the curriculum in itself continues to be great. But one of the things that even though I as a resident went through this curriculum, I noticed that when when the bullets start flying, for lack of a better way to say it, it's often very, very difficult to apply under pressure your ultrasound skills. And oftentimes, when you're scanning patients in the PACU and we're practicing, you have all the time in the world to basically get the view that you need to get. But in live situations, especially assessing trauma patients, assessing their heart function, and assessing really sick patients inside of the ICU. Even I noticed in myself that I wasn't able to get these in a timely fashion. Eventually you could be able to get it, but in these situations, oftentimes you have a couple minutes to get the views that you need to get, right? So. Mhm.
So do you think that, so let me take an example, that you're my faculty member and you took me into the PACU and, we're getting some basic transthoracic exam views, and I can take all the time I want to get those views and putz around and optimize the view. But you never introduced into my training to say, okay, look, I still want you to do this PACU patient and it's practice, but I want you to do this in 1 minute or something like that. You're saying there was no time pressure placed on it.
Exactly. And then also, not only just focusing on getting the views, in our OSCEs, we also focused on uh, uh, just interpretation of the view also. A lot of focus oftentimes goes into, oh, can you just get the peristernal long axis view? Can you get that view for the pleural effusion? But we really want to focus in on different portions of the exam, identifying different portions of the anatomy, and even going a step further as to doing interpretation things such as, okay, if I were to see a 10 centimeter space here in this pleural effusion, how much fluid would we drain? These are all different aspects of point of care ultrasound that need to be ultimately put together for the clinician to actually use the skill.
Yeah, I was actually excited to do this interview because one of the projects that we highlighted in another SCA webcast was a training tool for transthoracic echo. Also, yeah, let's just say transthoracic cardiac echo. And one of the modules, there was a series of online modules, and one of the modules was on interpretation. So it's just presenting you lots of different unknowns, clips, and that you had to try and provide an interpretation of those clips. And then you got to see the clip again, and then there would be an expert audio overread, essentially, reading the clip and pointing out the key things that were on that clip. So that's interesting that you say that, because I also agree. You have to try to break down training into component skills. And image interpretation is something certainly that we could do in a different environment than actually having to be in the PACU and obtain a view. I think that's super important. The physical hands-on for obtaining and optimizing a view. But I think it's interesting the ways that you can do for gaining skills in image interpretation. So we're going to present this webcast, hopefully one after the other with the other one. So
that's great. Yeah.
Two different approaches.
Yeah, and definitely POCUS is one of those things that requires so many different skills portion, right? And as you mentioned, one is the hands-on portion. Can they, and we're going to touch on this a little bit later when we get to something else I'm going to talk about, which is basically how do we validate one of the tools, the OSCE tool that we're going to be using.
Right.
So there's multiple components into going to this, right? So one is, can the resident do it in a timely fashion? Number two is the image itself actually a decent image? And how do we score that image in itself, right? And then number three is, well, can they interpret the image? Number four is the image quality good? Meaning, is the depth, is the gain, is all of that good? Number five is, are they positioning the patient correctly? All of these things are, point of care ultrasound is something that people say, oh, I can do point of care ultrasound, right? But there are so many factors that go into actually performing a good point of care ultrasound exam that we want to make sure that all of these points are hit on before we actually release the resident into the wild, basically.
Okay, well, awesome. Well, I think we're going to talk about that a little bit in some more detail in just a moment. Earlier, it sounded like you mentioned that you've got some collaborators. I don't know if you want to just mention a few of the people in your department that you were working with to help develop these OSCEs.
Yeah, absolutely. Actually, a lot of this not only was done within my department, but actually I have a lot of mentors and people that I'm collaborating outside of UCI. One of my biggest mentors was Dave Ramsing, who I'm sure you guys know about in the point of care ultrasound world.
Yes.
He was the one that published basically the Foresight curriculum back in 2012. He's one of my biggest mentors, and he was over at Loma Linda, especially when I was doing my fellowship in critical care over there. Other people, obviously, we have Joe Reinhardt inside of our department, who's great with research, and he's going to be doing a lot of statistical analysis for us. And Kyle Lon, who I'm also collaborating with in our department to do a actually retention study that we're going to be talking about also. And then also, obviously, our chair, Scott Ingwall, is super supportive of point of care ultrasound in itself. And this is kind of one of the other questions we wanted to hit on was what resources does a department require in order to even launch a project like this?
Yeah, let's kind of break it down into, not what resources you would need to actually to do what you're doing in your department, but for you to be able to create the project and drive the project. I always find that interesting, and I think it's helpful for other faculty members to hear, how you were able to garner those resources. I almost said garnish, so that's great. To garner the resources to do a project. I find that challenging. How did you get your chair on board? How did you get time? What time were you allocated? Did you have to go after any funding? Did you use medical students or residents? So tell us a little bit about that.
Yeah, so definitely number one, I think the thing that everybody needs is good mentors. I think that in order to have a successful launching pad, you definitely have to need the support of people and people that have kind of done things like that before, right? So, actually, in regards to point of care ultrasound in itself, as you mentioned, because UCI was so already invested in point of care ultrasound, a lot of the things at least the culture has been set that, focus is very, very important to our department, right? So the great thing is that, regarding getting number one, getting the curriculum through to the residents has always already been there. Also, getting dedicated ultrasound equipment. Actually, our chair was very, very supportive because if you only have one ultrasound machine for the entire department, doing point of care ultrasound is going to be very, very difficult, right? So we actually made it a point to purchase, and along with our actual institution, purchase many, many ultrasound machines so that it's widely accessible so that whoever wants to use it can definitely use it. Right? Number three, we also have dedicated ultrasound faculty. So basically people that are confident and good at doing point of care ultrasound come together and meet so that basically we can ensure that the resident education and the launching of the project is good. And number four is regarding time. I wouldn't say that I have a specific time able to do this, but a lot of this, especially the focus retention study that I've been doing with the multi-center trial that we actually have going on, is I would say is done a lot of it on kind of our own research time that we get sometimes, we get some academic days here and there, but I wouldn't say it's extremely consistent.
So you didn't have dedicated time
to do it for this. So I think there's three components, like I said, what I was talking about. Number one is the component of resident training, and that definitely has been built into our curriculum already. We have a very strong ultrasound curriculum that once I got here out of fellowship, I helped revamp. Our interns, we have a 2-week dedicated ultrasound curriculum, and they also have where they're just on point of care ultrasound, and they also get POCUS education days. CA 1, 2, 3 years, they all have 6 point of care ultrasound sessions within their education days, and then they also have OSCEs tied to those. So getting the residents portion and the performance portion up to par so that our residents can continue to have kind of good knowledge retention was not extremely difficult, because basically in the end we mixed the OSCEs into their education days and made it a part of their education so that it would continue to be basically carried out, and that way we could assess the residents' retention and their performance in addition to kind of throughout their education. Now, the research projects regarding retention, which I basically have two projects going on. One is actually a resident retention study that me and Kyle are actually doing. And then also my own kind of project that I've been doing with, which is a multi-center trial along with about 10 other institutions. Those are kind of all done on our, I would say, our own time based off of research.
Have you considered, I think this is a challenge for junior faculty, is to actually get enough time, and usually it means a lot of time on nights and weekends on your own time, and
yeah, that's correct.
do it, and it's pretty tough on people, actually. I mean, I know I struggled through that as I did many of my projects. Have you considered getting a FAIR grant? FAIR is an interesting organization, and they have some nice grants, and I think your projects potentially could fall well within their young investigator grants. They come with, I don't quote me on this, but let's just say approximately funding to your department in the range of $100,000 to $150,000, and they usually give you somewhere around 0.2 to 0.4 of an FTE of dedicated time to work on your projects. Mm-hmm. It's something that your chair has to agree to if you accept a FAIR grant.
Absolutely. I actually have applied to a couple grants. Maybe they actually didn't get accepted for this project, but okay. So I actually have tried in the past. These grants are extremely competitive. People have projects that are great that are going around the entire nation. So, but I definitely did apply to a couple grants. I think I did look into the FAIR one. I don't remember what happened with that one, but I definitely have applied to a couple grants.
I would encourage our young faculty members that are listening to this, if they have a great project, which we're going to get a little bit more into and you've only scratched the surface, but that was one of the things that came to my mind, is that this might be a great FAIR grant, the kind of things that FAIR supports. And as a previous two-time FAIR grant winner, I can, I say that with some background in this area. So absolutely. Make sure you take a look at that. Yeah.
Well, yeah. One of the things also is these grants, oftentimes I think, obviously also because of COVID and different things like that, we're encouraged to apply over and over again, right? Because sometimes you don't necessarily get accepted for 1 year, but maybe they'll choose you the next year again. So it's definitely something I'm going to look into again.
Okay, fantastic. All right, so we've talked a little bit about the resources. Tell us about, what was the final product? What did your final, when you got through with your project, or at least where you are at today, what have you already developed?
As I mentioned, there's kind of three components to the POCUS project that I'm working on. The resident portion, which is basically just implementing OSCEs into their curriculum. The second portion, which is basically this retention study that me and Kyle are doing, which we presented as an educational abstract at SEA this year. And also the third one, which is the multi-center tools validation project that I've been doing. So
before we get to those, let's break it down, because it's obviously there's a lot of things there. Let's talk about the OSCEs first.
Yes.
So, one of the first things that you had to do was you had to develop the OSCEs. Can you describe, give us one example of what one of these OSCEs look like?
Yeah, so basically what an OSCE is there's a very specific prompt and a structure that the resident comes in and it has to be able to perform these tasks under the supervision of basically an attending or the person administering the OSCE. So actually when the OSCEs first started, the idea, it wasn't designed to be an OSCE at all. Initially, when I first started this thing, it was called an interactive POCUS session. All I really wanted was for, instead of, because usually, and how I did it during my educational sessions were, we had a point of care ultrasound, for instance, hour or 2 hours, and then the faculty would go over a lecture, and then we get some hands-on time with a model in the room, and each resident would get a little bit of time on the probe, and then basically that would be kind of it. And then we'd say that, we're done for our education for the day. So the thing I found kind of bad about that was, number one, especially when you're doing cardiac, right? When you place the probe on the patient, the patient kind of develops this little red mark on their chest, right? Because of the pressure from the probe. So actually, basically every resident then just goes kind of in that same area and then does the scan, right?
Okay.
So the attending's already done the scan on the model. He develops this kind of red area, and then the residents just kind of, well, they do it themselves, but in the end, they end up in the same area because they were watching and seeing where they placed the probe on the patient, right?
Okay.
And then, mhm.
So how did you modify that?
Yeah. So
Indication?
what I saw was that basically that was not good for overall, because right when you have a fresh patient, you need to get this scan yourself. So what I really wanted was for the resident to be able to come in, not have seen anybody else do the scan on this patient, and then have to get the scan on the patient by themselves. So really, what we developed was a structured prompt for the faculty to basically say, we put all the residents outside of the room. We called them in one at a time. We said, hey, and then there was a very structured prompt that the faculty had to read. It began like, Dr. Shen, please position the patient appropriately for a parasternal long axis view scan, and when you're and select the correct probe for the patient. Once you're ready, I will give you 3 minutes to complete the exam. And that's kind of how this whole process started. Then basically the prompts then turned into grading rubrics that because each of the things that we wanted to score had a point system, and then eventually the rubrics became a full-blown OSCE, and then we started writing OSCEs for all the different types of point-of-care ultrasound skills, going from fast exams, the pulmonary exams, the cardiac exams, and basically now we have kind of a database of OSCEs at our program.
Let's back up just a little bit. So would a single OSCE involve a prompt coming in, a positioning, selecting the appropriate ultrasound transducer, and obtaining the appropriate view on a model?
That's correct.
Is that correct?
Yeah, and then also once we get the view, we actually then ask interpretation questions on that view. So
Okay.
what we usually do is we ask the resident or whoever we're testing to get the view. We will then freeze the image that they're on, and then in the correct view, and then we will ask them to identify some structures within the view. And
okay,
then
so
there,
identifying anatomy.
right?
Okay.
And then from there, we'll also sometimes ask an interpretation view, such as the one that I mentioned before. If you have 10 centimeter space here, how much pleural fluid can you drain? That's, for instance, one of the ones. Or sometimes
let me just ask a question about that. Does that mean that you would suggest, so one way to do it is you'd actually have to have a model that has pathology, right?
Mhm.
So, or you just bring in a standardized patient or a standardized model that doesn't have any pathology, you obtain the view, and then you would say, well, what if you saw X here? What would that mean? Which way are you doing it?
The latter, the second way that you talked about. So the standardized patient, then we say, hey, look, if this looked like this, or if this, what pathology, or how would you interpret this?
Okay, so the next thing is there's sort of phases to this, right? Where they come in and they have to do positioning and they have to do probe selection of the patient. And then there is image acquisition and image optimization. And then maybe the third thing, I'm just roughing it out. And then the third component is image interpretation. And so what you developed in your OSCEs was a scoring rubric for each one of these phases. So essentially checklist items that you had. Can you describe, give me some of the checklist items, and were they scored yes or no, or on a scale of, a Likert scale, or how did you score?
Absolutely. So, what we really wanted to do was eventually mirror what we thought the ABA OSCE is going to be. The ABA has come out and said, hey, we're going to be putting point of care ultrasound on the exam. Initially, it was 2021, but now they're saying 2022 or 2023, right?
Yep.
So what we really wanted to do was mirror the ABA OSCE. So our time limits are extremely similar. Usually, it's especially when we do our study, like our multi-center study, and we try to mirror this within our own residents also. They'll get 12 minutes for a total OSCE, 8 minutes in the room, and that's how it kind of works. And actually, they get a sheet beforehand that they read, similar to what they do at the ABA also. That's kind of introduces this scenario that they'll be going into.
Okay.
And then afterwards, they come into the room and basically, yes, there's a checklist. So, and it's scored in the similar way because one, Joe Reinhardt at our institution is board examiner. And the ABA scores their OSCEs based off of 3 criteria. Basically, it's a yes, somewhat, or no. It's either yes, they definitely got the view, maybe they got the view, or somewhat view, or definitely no. And some of the answers are definitely basically a yes or a no. And then sometimes it's a somewhat, depending on, and we actually have very specific criteria for what becomes a somewhat. For instance, for positioning, if we're doing an apical 4-chamber view, a yes would be the lateral side because that's what the left, basically with the left side down. A somewhat would be supine, and a no would be, for instance, if for whatever reason they do it standing, but that would be very strange. Yeah.
Now I'm just going after some of the technical things, and then we'll come back to this because I'm sure people are going to want to know, how they could look at your scoring rubrics for different OSCEs. But let's come back to that in a minute. So let's talk about the scoring rubric. First question is, how many checklist items were on a typical scoring rubric?
Anywhere between 5 and 7, usually. Anywhere between 5 and 7, just because of the limitation of the exam time.
Right, because of the exam time. Okay. And also the faculty ability. There's been a lot of research looking at the fidelity of competency assessments and checklists, and looking at the number of items on the checklist versus what's called a global rating score. So I could just give you one score for the whole session, and that actually correlates fairly well with a multi-item checklist. So it's kind of a gestalt. Let's say I take you on your driving test. You go to the DMV. I take my daughter in. She goes in for her DMV test. They drive around. There could be a lot of checklist items on was she able to parallel park, and did she hit somebody in the crosswalk, or whatever it is. And but then there's sort of the global, should you get your license or should you not, right? On a scale of 1 to 3, 1 to 5, whatever it is, and score. Yeah. Sometimes a global rating scale. So do you include a global rating scale in your one of the 7 items?
Yeah, so our OSCEs for our residents for general education are slightly different from our OSCEs for when we do research. When we do research, it's very, very much more similar to what you're talking about. We have a yes, no, maybe scale for each of the scoring points. And then we, in addition, also have another question on a Likert scale saying, hey, was this resident, in your opinion, generally competent in this ultrasound exam? And in addition, we also have, because the ABA actually on their own, when they score OSCEs in itself, they actually have a score that just basically says, was this resident basically performed at the level of an ABA diplomat, right? So that's just kind of like a generalized, did this resident pass? But that also includes a lot of other things such as professionalism, right? Did the resident come in when were they professional throughout the entire encounter, right? So these are all the things that go into kind of what you were saying. So
yeah,
when we do research, there is a 5-point scale that we do score the residents on. When we're doing just for education, we kind of just we do the generalized ABA question. Did this resident perform competently overall?
Wait, I'm sorry. Let me make sure I understood that.
Yeah.
When you're working with the residents in your actual program, you don't use the checklist. You only use a global rating.
No, we use the checklist in addition to the generalized ABA question, and then in our research we use the checklist, the 5-point scale, in addition to other things, basically to be more complete.
Okay. All right. Great. One of the challenges that comes up, and you're talking to a guy that's, of course, very interested in competency assessment, is when you have a checklist, it's how you decide which items on that checklist are, how do you score it? What's passing? Do they have to get 7 out of 9 yeses? or are there critical items on the checklist? If you miss this one item, even if you did everything else correct, you don't pass. What do you think is, how would you approach, this issue of pass or fail?
So for when we do education for the residents on on their regular generalized basis, the exam in itself is really for the residents and their own knowledge, right?
No, it's a formative thing, but I was talking about if you were doing a summative exam on a high stakes exam, like the board, for example.
Oh, okay. Yeah. So that's more along, I would say, the lines of what we're doing on our research end, because we actually have a thing that says, hey, if they got more than 80% of the questions right, then they definitely passed. If they got more than 60% of the questions right, well, then it's like a maybe pass. It's like a lower pass, and then anything below that is basically like a no pass. That's how we're scoring it more in research, especially with the views.
Have you generated some data that shows, about that? Like I said, the correlation between the more global rating and your cutoff values.
Yes, so that's actually one of the things that we presented recently at SEA on our retention study. This study is regarding. So what we basically did for this study was we at our intern class, they had a focus rotation. At the end of the rotation, we gave them an OSCE, and then a month later, we gave them another OSCE, and then 6 months later, we give them another OSCE.
Sure.
So basically, what we found was that there is knowledge degradation over time, but similarly, as we mentioned, each resident is scored with were they a suitable performance of an ABA diplomat, right? And basically, the less questions that they got right, the more correlative to basically that they weren't an ABA diplomat it was.
Okay. Well, that brings up another question, but we'll have to forgo that because I have some more things that I want to talk to you about. But we do have this problem with competency assessment in residents, that they may perform at the level that we would like them to for graduating from residency at some point in time, but because of the skill degradation, they don't do any regional blocks for 6 months before they graduate, or they haven't done an X, Y, or Z, and you see a degradation. Then, quote unquote, are they still passing at that point? But we'll skip that for a moment. What I'd like to ask you is, first of all, how many OSCEs are there in your library?
So I don't know what the exact number is at this point, but we definitely have about, I would say, because we also do this for TEE, also for cardiac. So we probably have along the lines of somewhere like, I would say like 6, 7 cardiac OSCEs, somewhere around there.
Yep.
Pulmonary, we probably have like maybe like 3. And then, we also have like a volume assessment, things like that, which involves the IVC, getting the the cardiac views at end diastolic diameter and end systolic diameter, different things like that. But overall, I would say probably around the lines of around 15, I would say at this point.
And what I heard you say is that you cover TTE, that you cover lung exam,
Yep.
and I'll throw volume assessment in there with TTE. Do you do any things related to the FAST exam?
Yeah, we also do FAST exam, and we actually also do gastric antrum exam also to test for gastric volume.
Okay, and then anything else in there, airway or any of this? Are those the form?
Yes. So we definitely have also a portion. We also have airway exam also, but that one is a little bit. It's difficult to do an airway exam on. Usually, we're doing them on intubated patients to see, for instance, where the cuff ends up lying on. But obviously those are some are definitely lower yield, I feel like, than others.
Yeah, I mean, I guess, whether there's clinical evidence as to whether or not there actually supports their use, for example, like even gastric ultrasound, there's some questions related to gastric ultrasound. Okay, and then do you think in our given residency program, let's say you've got 15 OSCEs, would it be in your intention that they would get exposed to all 15 in their 3 years of training once, or what's your vision? If you had a magic wand, how many times would they have to go through this OSCE?
So currently, what we have at our program, just because of limitation of time, is we have so the interns get 3 OSCEs. So 1 at the end of their exam, 1 a month out, and then 1 6 months out. CA1 residents get 2 OSCEs throughout their entire year. CA2 OSCEs get 2 OSCEs, and then CA3s get 6 OSCEs, because every single one of their focus education days comes with an OSCE. So, and the reason why we did it this way was that, so intern year, you're just really introducing a couple topics. By CA1 year, you're going through the entire kind of point of care ultrasound curriculum at a surface level. CA2 year, you're going through it at a much more deeper level. So you're going back again, and this obviously the SCA has been shown this many times that doing something even in education over and over and over again obviously benefits. So we're going back to the same topics, and then we're going slightly deeper. For instance, the first time we do volume assessment, we may only talk about IBC and things like that. But second time we go around, we talk about how, for instance, VTI and how different stroke volume variation and different things like that approach are used. And then the third time around that they're in their CA3 year, you're going over all of these topics again. However, they have an OSCE attached to it, so that when they actually do the OSCE, the attending can actually be much more focused on, hey, this is the portion that you're really missing out on.
Okay. Do they have time after the OSCE to get additional training in whatever weakness was identified in the OSCE?
Yeah, so what usually happens is the resident comes in for the OSCE, they each go through the entire prompt, and then usually right after the prompt, I'll immediately go over with the resident what they did wrong there. That way, and then as a group, you come back together and then go over, hey, so these are the things that most people kind of did wrong that day. Let's talk about why we need to fix these portions.
Okay, I like that. I like that that follow-up teaching there.
Yeah.
Now, this sounds fairly labor-intensive, essentially, in terms of faculty time to be able to run that number of residents through, right?
Yep.
So you'd have to run a whole class through on one of your 6 education days.
Yeah, so exactly. So actually, during this time, we always have 2 attendings dedicated that day. And so they split the class up. And then we have 2 stations that go at the same time to make sure that actually all the residents can get through. So for these POCUS education days and OSCE days, we hire 2 ultrasound models, and we have 2 machines with 2 dedicated attendings that are POCUS faculty, so that we can, and we have.
Does it take them all day, or are they there for a half day?
No, our education days are all full days.
Okay.
Why we can do this. Yeah. Usually it takes about 2 to 3 hours to do a session like this.
Sorry, just to make sure that I understand that correctly.
Yeah.
Your faculty time investment would be only 2 to 3 hours on one of those days, because they're going to be doing other things on that day.
No. The faculty is dedicated to education that entire day, both of them.
But would all of that time been done with the OSCEs?
No. It's probably only about a half day.
Okay, that's what I was trying to get at.
Yeah.
So 2 faculty for a half day to run a medium-sized residency program.
Yeah, so we have about anywhere from 10 to 12, depending on the class year now.
Yes.
So yeah, that's about, usually 6 residents per. Usually,
okay.
Yeah. Mm-hmm.
So I see that as one of the potential barriers about whether how programs are organized, that they have enough time to be able to
definitely
do that.
I think that's one of the major reasons why we move towards full education days for our residents, as opposed to before the operating room or something like that, which a lot of residency programs do.
Right. And then how many of those full education days do they have a year?
So they have, I believe it's 12 or 13. Yeah.
Okay. Okay.
So basically once a month.
Did the implementation of the OSCEs in your program, because it's quite a bit, did it take you only have so much room, right? Did it take up some of the oxygen in the education? Was there something it had to replace, or did you just have to expand your education days to make room for this new education?
Yeah, so what we found was that residents really enjoyed interactive sessions much more than lectures, right? So actually the education days, we really have shifted more towards trying to get the residents more interactive, doing PBLDs, doing things like this to really engage them. Or else a full, 8-hour lecture series in one day is just not beneficial for the residents towards the end of the day. So really what we usually do is we start with some lectures, we break off, we do OSCE stuff, POCUS stuff, and then we come back after lunch, and then we do maybe some more lectures, and then maybe some, simulate something to basically either usually have simulation or they have basically OSCE, something like that to make sure that it's not so monotonous.
Okay. What are the barriers, if any, to a program implementing? If I said, well, we want to do this here at OHSU, you'd say, hey, well, Glenn, make sure you take into account, this, because this is going to be a challenge. What would you put into that category?
So I would say number one is one of the main things is whether or not you have enough faculty to kind of run your residents through, right? Dedicated faculty that are dedicated to point of care ultrasound is super, super important. I think as we talked about before, point of care ultrasound is something that is not every single attending is very familiar with, depending on when they train these days, right? So
like the old farts like me is what you're
that's not, yeah, but it's definitely the case. We have some faculty that are extremely familiar with it, others that that know point of care ultrasound, but just not as such on such a deep level. Yeah. And then another thing I would say that's a barrier is definitely equipment. You have to have it's always beneficial for your residents to be using to be running the OSCEs and testing on the same equipment that, for instance, they're using throughout the regular day, right?
Yeah, that makes sense.
Another thing is definitely funding for models is a huge barrier. I think that our department does a good job at basically paying 25. I think it's like $25 an hour to hire basically some medical students. Most of the time, they're med students that volunteer that come in. They basically pay them like $25 an hour or something to get that going. But that in itself over the whole year is definitely a significant chunk of change, right?
Yeah, I'll throw this out there because a number of programs, what I've heard, is even scanning medical students. There's some issues about power differential and a perceived possibly making other residents, faculty, or medical students uncomfortable. So actually having paid professional models, is a big benefit to a program if they're able to utilize them.
Definitely, I think that's one of the main reasons why we always pay our models. At least it's they're not just coming to volunteer, and there isn't that power differential. At least they know what they're kind of getting themselves into, and they're getting paid for it. Other things, I definitely think the time factor of education days is a huge barrier that many other programs have to overcome. There's benefits and drawbacks to having one day of education for the residents a month, right? So basically, the CA1 class gets 1 week, the CA2 class gets the second week, the CA3 class gets the third week, and so on, right? So, and you have to get all of those residents out of the OR for that one day. And so the benefit is that all the residents are together, there's dedicated time, they don't get interrupted, they don't get paged, they don't get anything, right? The drawback is that they only get 1 day a month, right? So it's then you have to heavily rely on your operating room teaching and different things like that to ensure that the residents' education is up to snuff. And I guess that's definitely going to be a barrier for programs that.
They do afternoons or beforehand. I think maybe one of your unspoken barriers there too is it's not just the OSCE part of it. You have to have the curriculum, the basic and advanced curriculum that you've put together. So that's a whole nother issue. But let's maybe I'll touch on that at the very end as I ask you another question.
Yeah.
But before I do that, I have one more question before we sort of get to the wrap up part, is just about how did you measure success of your project, you know?
Yeah, so we get obviously a lot of resident feedback. I think that because each educational day has resident feedback and evaluations about that educational day, and also getting on the ground and actually talking with the residents is extremely important. I think that for me as point of care ultrasound director, I basically meet, the seniors go through, they also have their own POCUS education kind of dedicated weeks. So getting with them and the interns, and I meet with them on basically a 2-week basis. Residents rotate through and seeing what they actually need is extremely important. Also, just getting enough feedback for your course evaluation and actually the educational days, I think is how we really measure whether or not the residents appreciate or actually find beneficial what we're doing. Right.
Now, did you do anything else? I know you've got some research projects going on. You mentioned a retention study, so you can look at whether they're retaining, knowledge and skills over time. A common educational design is a pre and a post, some sort of an exam to see whether or not before you implemented the project, how are your residents performing on their POCUS skills, and then after you did these formative OSCEs, how they were able to do. Obviously, that design is fraught with a lot of problems, but yeah. Did you do anything like that where you were looking at what do you feel like, and did you measure in any way that your residents graduating today have a higher competency level in POCUS than they did, let's say, 3 years ago?
Yeah, so I think that definitely the POCUS OSCE tool is a new tool in itself. It's something that has not been fully validated yet, because we have to validate our actual exam through different methods, and not only just so that's definitely something that we're currently working on. And so as I mentioned, we have this multi-center study going on.
Let me interrupt for a second, just so because again, the purpose of these things is to help educate junior faculty. So there's really two aspects of what you talked. There's some nuances of the question that I asked. One is you talked about the validation of a competency assessment tool. Yeah. So how do I know that this tool, if you score X, that really means that you are competent in whatever the behavior or skill that we're trying to assess? So you're undergoing a study right now to validate that. And there's a number of different methodologies that are used to validate competency assessment tools. So for example, one method might be looking at different time points in training and giving them the exam that you've developed, or the competency tool that you've developed. And you would be able to just demonstrate that individuals that had varying levels of training score differently on the tool than they do. People with higher levels of experience score better. That's one thing. Another way to do it is to compare the outcomes on your exam or competency assessment tool compared to some other quote unquote what's called a gold standard. If there was a gold standard that exists, which does not in yours. Right. But I'm going to point out one other thing, and that is that validation of a tool is a process. There are many things that go into the validity of a tool to determine that it is valid. And you've already undertaken some of the very first steps in that, which are, content and construct validity, where, how you developed the tool, what experts you did, what pre-work you did to show that, these were the skills and behavior that you should be assessing. That's also part of the validation process. So I just point that out for people.
Yeah, I think that we're just barely scratching the surface of currently POCUS tool validation. I think that this is something that everybody, even at the ASA level, is extremely interested in, is how do we ensure that the people that, say that they can do POCUS actually can do POCUS, and then the tools that we're using to validate them are actually valid. And this is something that we're just barely scratching the surface currently. And regarding
another thing that people might do is, in a study like this, is they might look to see if performance on your OSCEs was correlated with performance on the ABA exam.
Exactly. And
so, you know, you have to work with the ABA in that example to get anonymized data to be able to do that study. And they're, of course, quite interested in that. But what's really interesting is that you're comparing one unvalidated tool to another tool, and you'd have to look at the, you know, the evidence for validity of the tool that even the ASA is using, or the ABA. I'm sorry, but they've got some really good experts in this area, obviously. But so I just point that out.
Correct. I think that you know, our goal is to hopefully publish our study before the first ABA for the point of care ultrasound OSCE is administered.
Right.
Then I actually reached out to the ABA to see, hey, you know, we're doing this study. We're going to have 100 something residents at 10 over 10 programs. Are you guys interested in being a part of you know, what we're doing? And at this point in time, I think that what they're looking for, exactly what you said, is over time we're going to be doing comparative studies. Is something that they may be interested in the future.
Right.
Then so that's one of the things on how we're measuring our project successes and how we're continuing to do research in this field is through this validation tool. The other thing that I mentioned, as you kind of talked about before, was our retention study. So this, we actually do have some data. It's not completed yet. Our current intern year is almost done with all of them going through the 6 months, and we're going to have a complete data set. And what we did show at our recent presentation at the SEA as an educational abstract was that basically knowledge degradation happens probably somewhere around you know, 2 months is what it looks like.
Right.
So we do have data collecting going on forward and how we're going to continue to, you know, when we're going to reassess our residents, how we're going to continue to stimulate them at different times to ensure that they maintain their knowledge. You know.
I have a quick question about the design of your multi-institutional study, and that is, do they all have this? Are they all using the same curriculum? So they're all using the same competency assessment tool, but it'd be quite curious to find out if the heterogeneity in how we teach focus skills and knowledge in our programs, did that produce heterogeneity in the scores?
Exactly. So that's one thing, is that all we did in our multi-center study, so this is basically a pilot study. It's the first, I created, along with Dave Ramsing, a consortium of institutions that basically we got together and we said, hey, we're going to perform point of care ultrasound OSCEs on our graduating CA3 residents. Okay. And then all of us have different point of care ultrasound curriculums. All of us have different exposure to, you know, everything throughout residency. All we're going to do is this one study for our graduating CA3s right now. It's the how they perform actually on this one test probably isn't very indicative of much. Let's put it that way, because it's one test on the graduating CA3 residents, and in that in itself, you know, there's so many factors that can go into having one test. But what it does show, what it does allow us to do is, one, launch additional studies from here that are much larger, and two, it does allow us to, exactly what you were alluding to, kind of see, hey, we're going to anonymize all the data from all the programs and say, you know, programs that have maybe had this much ultrasound time, their residents got these scores, maybe, you know, and it's all going to be anonymous. So that basically it's just a correlation currently, and that we're just launching this small pilot study, but in the future, we hope to basically do a lot more with this.
Yeah, unfortunately, one of the unanswered questions in a lot of anesthesia training is, what exactly doesn't a graduating, despite the creation of milestones, what does a graduating resident skill level look like? Like, even as an expert in regional anesthesia, I don't know, at the end of graduation, should we expect all graduating residents across the country to be able to place an axillary block?
Right.
You know, that question actually has not been answered. So you're doing some great work. It's been great to have you on the program, but I always like to finish with, wow, you've done something awesome, but hey, I'm sure the University of Texas at Houston would love to, be able to do some of the things, or here at OHSU, we'd like to be able to do it. So how can we share some of the materials that you've done so that we can try and utilize those OSCEs you developed?
Absolutely. So one of the things is the Foresight curriculum is actually free for everybody to use. There's so much point of care ultrasound curriculum that's either you have to pay for or not pay for, and you don't know what's actually good or bad. The great thing is that Dave Ramsing developed a website, and he continues to run this website by himself. And you can basically go into Google and type Foresight Ultrasound, and there's an entire website with basically the entire Foresight curriculum is on there.
Okay, so that's free to access for all programs. Okay,
everybody to access. Yeah.
All right. How about your OSCEs?
So OSCEs, I'm going to be working alongside with Dave Ramsey to probably get our OSCEs on that website for one thing, and in addition, we'll be publishing our OSCEs on the Anesthesia Toolbox also.
Okay, fantastic. Well, great project, lots of work. I hope you get funded because you deserve it. You're doing something really important in our specialty. So I hope you get funded, and so you can get some time, and then maybe your family will be able to see you a little bit more all the nights and weekends you've been putting it. So thanks so much for joining us, Jay. Fantastic project.
Thank you so much for having me, Glenn. It was really a pleasure. Thank you.